Back on Saturday, we will have a wellness room. So if you can at all take a break from some of the more medical and heavier sessions, then we'll have a wellness room for you to go and get a massage and try some yoga and get some relaxation done. So now we have Joanna, who is from Triage Cancer here, and she's going to talk to you about finances and all the not so great stuff. So we just got all shook out and we're all relaxed, but hopefully we won't stress you out too bad.
So while we're waiting for technology to catch up with us, how many of you are actually from California? Maybe I should ask the opposite. Who's not from California? What states are you from?
Missouri.
Missouri?
Tennessee.
Tennessee?
New York.
New York?
Texas.
Texas. Any others? Okay. So I get the pleasure of talking with you today about navigating insurance and finances, and I'm not quite sure how I get to follow what's just come before, except that walking on broken glass might be my new metaphor for talking about health insurance. So to start with, I wanted to tell you a little bit about the work that Triage Cancer does and the programs and services that we offer so that you know where to go for more information about what we're going to talk about. But I did want to ask, how many of you have private health insurance, either that you buy individually or you get through your employer? And how many of you have Medicare? And how many of you have Medicaid? Okay. Can I take the laptop from you? Does that make it easier if I advance the slides?
Sure.
Okay. So Triage Cancer is a national nonprofit organization that provides education on all of the practical and legal issues that come up after a cancer diagnosis, which really just means about everything. And we do that through the hosting of free educational events across the country. We have actually delivered in-person educational programs in every state except Vermont, which we will get to in November of this year. And that takes the form of events like our Triage Cancer conferences, which are free events for everyone. And we do have two coming up in Chapel Hill in Houston, so for those of you who are in Texas. We will be there on the 28th of September. And we also have a free webinar series on a variety of different topics. And if you aren't able to watch them when they're live, you can actually watch the recordings. And I brought some materials that I've left on the table over here about the different programs and services that we offer, including the calendar of our webinars. And then we also provide educational materials on a variety of different topics, some of which I'm going to talk about today, but you can download them from our website at any time. And we also have state-specific resources because there are lots of things that are very specific to where you live, including the laws that are available that provide protections and benefits that you can access to help navigate through a cancer diagnosis. We also know that everybody doesn't learn in the same way. I happen to be a visual learner, and not everyone is going to read our educational materials. So we do have a series of animated videos that cover some of the key things that we think everybody should really have an understanding of, like how to use your health insurance or how to pick a health insurance plan. And then we also host an entirely separate website called cancerfinances.org, which provides education on topics that can have an impact on your financial situation, and then connect you to resources for financial assistance. But what is unique about this site is that you can actually go on and pick a topic and then start to answer some questions based on your situation, and then it tailors down the content based on how you've answered those questions. So you can get the information that's most relevant to you. And then we also have an educational blog and our monthly newsletter, but our blog is where we share a lot of late-breaking news, and we are constantly surveying what's going on at the state and federal level in terms of legislation or new policies to see how they might have an impact on the cancer community. So if you don't want to have to read all of the listservs and newsletters that I have to, this is a good way to stay on top of what's happening. So with respect to health insurance, the difficulty in talking about health insurance is that I think that no one really understands health insurance to begin with. And this includes people who work in the health insurance industry and our healthcare professionals. So if you feel like you don't understand your health insurance, you are certainly not alone. And it's not just my opinion of it anymore. We have plenty of data that shows that people don't have an understanding of how to even use their health insurance or what they're paying for. So to make sure that we're all on the same page, there are some key terms that are important for everybody to understand about their own health insurance coverage, regardless of where you get it from. And I'm also going to use these terms throughout the presentation. So there are costs that we pay just to have health insurance. It's typically our monthly premium. It's what we pay just to have the coverage. If we never got medical care all year, we'd still have to pay our monthly premium. But then there are costs that we pay when we get certain types of medical care. And the first is our annual deductible. It's what we pay out of pocket first before our health insurance coverage even kicks in. And you might have a $500 deductible, or you could have a $5,000 deductible, depending on the type of coverage that you have. And then there's something called a copayment, and that's a fixed dollar amount that you have to pay when you get certain types of medical care. So you might have a $10 copayment to go see your doctor, or you might have a $40 copayment to see a specialist, or a $200 copayment if you go into the emergency room. The amounts are going to depend on the type of coverage you have. And that's different from coinsurance or cost share. And those are two terms that are used the same way. And unfortunately, in the realm of health insurance, you'll find that there are at least two names for everything just to make it super easy for us to navigate. So coinsurance and cost share is a percentage. It's the difference between what an insurance company pays for our medical expenses and what we pay for our medical expenses. So if you have an 80-20 cost share, the insurance company pays 80% and you're responsible for 20%. So Medicare Part B would be an example of an 80-20 plan. And then there's something called an out-of-pocket maximum. And this is probably the most important thing that anyone should know about their health insurance coverage. Because in a worst-case scenario, it's the most that you're going to pay out of pocket during the year for your medical expenses. So at least it gives you a number that you can start to wrap your head around and even plan for. But the out-of-pocket maximum is a fixed dollar amount, and how you reach that fixed dollar amount is a math problem. So you get to add up what you pay for your deductible, plus any co-payments that you pay, plus any co-insurance amounts that you pay during the year to help you reach that out-of-pocket maximum amount. And when you do, your insurance will kick in at 100% for the rest of the year. So to give you an example of how this actually works, David has spent a week in the hospital and walks out of the hospital with a $102,000 hospital bill. But he has a plan that has a $2,000 deductible. It's an 80-20 plan, and he has a $4,000 out-of-pocket maximum. So assuming he's had no other medical expenses during the year, how much does he actually have to pay of that $102,000 hospital bill?
$6,000.
It's $4,000, but this is how you get there. So first, he's going to pay his $2,000 deductible, because that's what he has to pay first. But that still leaves him with $100,000 left of that bill. He has a 20% coinsurance, so he has to pay 20%, and the insurance company is going to pay 80%. That still leaves him with $20,000. How much of that $20,000 bill does he have to pay? He only has to pay $2,000 because at that point he'll have paid $4,000 out of pocket and he'll reach his out-of-pocket maximum. So the insurance kicks in and picks up the rest of that $20,000 bill. So again, I'm not suggesting $4,000 isn't a lot of money, but at least it's an amount that you can start to wrap your head around, and there's a maximum. So it allows you to know that that's the most that you'll pay out of pocket for the year. And it's certainly better than the $20,000 bill he'd be left with if he didn't have an out-of-pocket maximum, or certainly the bill he started out with. But in this example, for example, at Medicare Part B, that 20% doesn't have an out-of-pocket maximum. You pay that 20% all year long. We'll talk more about that in just a minute. So the Affordable Care Act, which is also referred to as the ACA or Obamacare, or its full name, the Patient Protection and Affordable Care Act, had a requirement that everybody have health insurance coverage. And that really only applies to about 10 to 12% of people in the United States who don't currently have health insurance coverage. It's a lot of people, but percentage-wise it's pretty low. And each year what you would pay as a penalty if you didn't have health insurance went up a little bit. And then in December of 2017, Congress actually eliminated the penalty and made it zero. So there's still technically a requirement that everybody have health insurance. It's just that the penalty if you don't is now zero, beginning January 1st of this year. The ACA also did some things to create some consumer protections for people around health insurance that have had a big impact on the cancer community specifically and on people's finances. And so I just want to highlight a couple of those. The first is that there can no longer be lifetime or annual limits on policies. So previously we would see patients with a $75,000 annual limit, or even a $1 million lifetime limit is not hard to reach when we're talking about how expensive cancer care is. And so once you reach that number in medical bills, you would effectively be left uninsured, and you couldn't go buy a new health insurance policy because you had a pre-existing condition. So this was a huge factor in terms of people's medical debt and the high rate of bankruptcies in the United States. So under the ACA, there's no longer lifetime or annual limits on policies. The ACA also said insurance companies can't try to cancel your policy when you try to use it, which sounds like something that shouldn't happen, but was happening so often that in California, we were actually looking at legislation to fix this issue at the time that the ACA was passed. And there was a lawsuit against many major insurance companies, and they found that insurance companies were paying bonuses to their employees if they could find a reason to cancel your policy. And that's no longer allowed under the ACA. So unless you commit fraud on the application, they can't cancel your policy. So don't do that. Then the ACA said, we know that young adults are chronically uninsured or underinsured, so we're going to allow them to stay on their parents' health insurance coverage until they turn 26. You no longer have to be a full-time student or a dependent under IRS standards. It's just based on age. So even if that 26-year-old is married, or the person under 26 is married, they can still be on their parents' health insurance plan. And then the ACA said we want to try to improve the overall health of society, so we're going to let people have access to free preventive services. And by free, I mean zero out-of-pocket cost. So you don't pay your deductible, you don't pay a co-payment, and you don't pay a co-insurance amount. And it's a specific list of services, but it's all sorts of things that you would expect in an annual checkup. So blood pressure, diabetes, cholesterol, cancer screenings, immunizations, flu shots, those are all supposed to be zero out-of-pocket cost to you. And then the ACA said, we want to encourage people to participate in clinical trials. So we're going to make insurance companies cover the routine costs of participating in a trial. And the routine costs are things like your office visits and your blood work and your imaging scans. All the things that would have been part of standard of care have to be covered by your insurance. And then the ACA said, sometimes insurance companies deny coverage for things, when really they should actually be paying for your medical care. And so it created a right across the country to not only appeal inside your insurance company, to ask them to reconsider a denial of coverage, but to get to go outside of your insurance company to an independent or external medical review. Now, California's actually had this as law since 2000 maybe, and maybe about 25 states had some version of external appeals, but the ACA made it federal law across the country. And this is, I think, one of the best kept secrets of our healthcare system. There's something like 2 billion claims that get filed every year, but I read an article the other day that says something like only 200,000 of them get appealed. And what's even scarier about that is that in California, 60% of the time decisions are being overturned, and insurance companies are having to pay for that care. So that means 60% of the time insurance companies are getting it wrong, which means patients actually either aren't getting the care that they need because they can't afford to pay for it out of pocket, or they're paying for it when their insurance company should have been covering it. So this is definitely something I recommend if you come across a situation where your insurance company is refusing to pay for something, pursue these appeals. And we have on our website the state agencies who are responsible for doing this in every state. So then, if there was nothing else in the ACA except these two things, it still would have been game-changing for the cancer community. The first being how insurance companies decide how much to charge us for our health insurance coverage. And that process is called premium rating. So previously, insurance companies could look at whatever they wanted to when deciding how much to price a policy. And now they can only look at four things: whether or not you're buying a policy for an individual or family, because if you're covering more people, they can charge you more, where you live based on your zip code, your age, but they put a cap on how much more you can get charged as you get older, and there was no cap previously, and whether or not you use tobacco. So if you use tobacco, you can be charged more for health insurance coverage. And then there are a handful of states like California that after the ACA was passed a state law saying we're not going to let insurance companies look at tobacco use in California. So in California, there's actually only 3 things you look at. So what's missing from this list? Pre-existing conditions. What else? It applies to at least half the people in the room. Gender. Women have always paid more than men for health insurance coverage, and that's no longer allowed under the ACA. So then the ACA went one step further and said, we're not going to let insurance companies deny people coverage based on their age, their gender, their pre-existing condition, or really anything else. As long as you can afford the policy, they have to sell it to you. So these two things together mean that anyone who's been diagnosed with cancer can't be denied health insurance coverage and can't be charged more because of it. So the ACA was signed into law on September 23rd of 2010, and these protections didn't go into effect until January 1st of 2014. I held my breath during those years because I didn't think this would actually happen, because it was such a big change to the way that our healthcare system works, and really has changed the way that people who've been diagnosed with serious medical conditions can access healthcare. Now, unfortunately, there's been a lot of challenges to these protections. I'm just thinking again about the states who are represented in the room. In the last 2 to 3 years, there have been a lot of conversations around repealing the Affordable Care Act and protecting the pre-existing condition protections that are in the law. But most of the time, those conversations are only focusing on the second piece. But the second piece doesn't mean anything without the first piece. It doesn't really help me to say that an insurance company has to sell me a policy if they can charge me whatever they want for it. Because then they can just price me out of the market, and that's not really access. So when we talk about pre-existing condition protections, that's why those two things have to come together for it to really make a difference for people. Now, I'm not going to go into all the changes that have happened over the last year, because no one's from those states specifically. But in January of last year, 2018, there was a lawsuit filed in Texas by 2 gentlemen who felt that the Affordable Care Act was no longer constitutional because Congress repealed that penalty for the requirement to have health insurance coverage. So in addition to those 2 gentlemen, the Texas Attorney General and 17 other Republican states Attorneys General joined in that lawsuit. So they all filed that suit in Texas. And I just want to say what I'm about to explain is not political. I'm just giving you the rundown of what's happened. So then in June of last year, the U.S. Department of Justice, who is responsible for defending federal laws in court, made an announcement that they weren't going to do that. They just weren't going to show up in court to be on the other side of this case, which is kind of unheard of. It doesn't happen very often. So in response, we had the California Attorney General and 16 other states' attorneys general asked to intervene in the lawsuit. So they said, can we step in and actually defend the ACA in court? And so the judge approved that. And then that court case was heard in September of last year, and that judge in Texas ruled in December that the ACA is unconstitutional. And then released a decision saying, I'm going to stay that ruling, which means he's going to put it on hold as this case works its way up through the court system. So then, the California Attorney General and those 16 other states filed an appeal to the Fifth Circuit Court of Appeals. Then we had an election in November of that year, and there were lots of turnovers in governorships, and some governors actually pulled their states out of the lawsuit. And the US House of Representatives actually passed a resolution to join the lawsuit to defend the ACA. Then a couple months later, the US Department of Justice came out with an announcement that said, we weren't going to defend this case in court, but we thought some of the things in the ACA should stand. Now we think the whole thing should go. So, on July 9th of this year, the Fifth Circuit Court of Appeals actually heard the case, and we are waiting for a decision right now. So the reason I went through this whole explanation is to say that all of the consumer protections that are in the ACA may go away at any moment, actually. And even though the Fifth Circuit Court of Appeals, however they decide, it will likely be appealed up to the Supreme Court, and then we'll wait for a Supreme Court decision on this issue, there's one circumstance where it may not be appealed. One of the issues that the Fifth Circuit asked the attorneys to brief and argue was whether or not the California and other states' attorneys general and the US House of Representatives actually had standing to appeal the case. Like, was it even okay for them to be arguing the case? If the Fifth Circuit rules they didn't have standing, the Texas judge's decision stands. And that could happen any moment. So, as a lawyer and someone who has done this work for a long time, this is an interesting look at our legislative and legal process, but it has very real implications on pretty much everyone's daily life in the United States. And I think that most people don't really know that this case is going on. But I do feel like I have to say that all, because if I talk about these protections and the things that are in the law, they may go away. So in the United States, there's only 3 places where we get our health insurance coverage. We're either getting it directly from an insurance company, we're getting it from the government, or we're getting it through our employer. And still about 50% of people in the US get health insurance coverage through an employer. So for those of you who have employer-sponsored coverage, if at some point you were to lose access to that coverage, you would likely be eligible for COBRA. And COBRA is a federal law that allows you to keep the same health insurance coverage you had for an additional period of time. But it only applies to people who work for an employer with 20 or more employees. And the downside to COBRA is that you're responsible for paying the full amount of what your employer was paying for your premium. And I always say that we don't appreciate what our employers pay for our premiums until we have to write that check ourselves. But how long you get to keep COBRA depends on your qualifying event. So if you are losing your job, for example, or you're leaving your job, you can keep COBRA for 18 months. If you're a young adult under the age of 26 and you age out of your parents' coverage at 26, you can keep COBRA for 36 months. If you work for an employer with fewer than 20 employees, then you'd actually be looking at your state law to see if there's coverage that's similar to COBRA. And almost every state has some version of a state COBRA law, but they're all really different in terms of how long you get to keep COBRA. So I'm pretty sure Texas is 3 months, and California it's 36 months, which is the most you'll find across the country. Now, some people say, well, why do I even want to bother with COBRA if there's other options out there? And one example would be if your employer coverage is really good, you might want to keep that. If your employer coverage is really bad, you might not opt for COBRA, and you might want to look for something in the marketplace. But one thing people forget about is about leveraging your out-of-pocket maximums. So if it's March, and you've already met your deductible, and you've already met your out-of-pocket maximum, you know that all you have to pay for your health care for the rest of the year is that COBRA monthly premium. versus getting a new plan and having to pay that monthly premium, plus having to meet your deductible and out-of-pocket maximum again. And when during the year that happens could be a big difference. So you have to do a little bit of math to see what's going to be most effective for your coverage, but also in terms of cost. Now, if you are eligible for COBRA and you're having trouble paying your monthly premiums, this is another good secret of our healthcare system. If you are eligible for broken glass, just to remind you how painful this all is, the Health Insurance Premium Payment Program, or the HIP program, is actually a program of Medicaid. So if your income qualifies, you meet the other eligibility requirements for Medicaid, instead of getting your care paid for by Medicaid, Medicaid in your state will actually just pay your private insurance premiums for you, because it's cheaper for the state program to pay the monthly premiums than it is to pay for all of your care under Medicaid. So it is totally worth taking a look to see if you qualify for that program in your state to get help paying your monthly premiums. Now with Medicare, I could spend probably 8 hours just talking about Medicare and what you should know about Medicare, but it is one of the 2 federal health insurance programs, this one specifically being for individuals who are 65 or older and eligible for Social Security retirement benefits, or someone who's been receiving Social Security disability insurance benefits for 2 years. Also, end-stage renal disease and ALS are 2 automatic qualifying conditions for Medicare. Now, Medicare comes in different parts. There are different parts to the coverage. So Part A is hospital insurance. So that's actually for hospitalization. So when you're in the hospital, that's what Part A is going to cover. It also covers some skilled nursing care and some home health care, and it covers hospice, but it's primarily hospital insurance. Part B is medical insurance. So it's covering all of your care except hospitalization and prescription drug coverage, which is available under Part D, as in dog. Now Part A and Part B are what we refer to as original Medicare, because that's all that existed when it was signed into law in 1965. We only added prescription drug coverage to Medicare in 2003. Part A most people get for free because you've paid into the system. Part B has a monthly premium, which this year for most people is $135.50 a month. Part D, what you pay is going to depend on which plan you choose, and you have to go to a private insurance company and pick a Part D plan. Or you could opt for Part C, which is getting your coverage of Part A, Part B, and Part D in an Advantage plan, which is Medicare Managed Care. If you go down the lane on the left, you can go to any doctor across the country who takes Medicare. It's fee for service. If you opt down the lane on the right, you're limiting the choice of providers because you're picking a plan that has a specific network of Medicare providers. So the way that you make these choices in private insurance, it also exists under Medicare. So Medicare Part C might be less expensive. You might be getting some additional benefits, like maybe dental care, that original Medicare doesn't cover, but you're giving up some choice. And so you have to weigh those options to see what's better for you. But one of the most significant benefits to Part C is that it has an out-of-pocket maximum, which this year is capped at $6,700. Whereas I mentioned before, if you're getting care down here on the left, Part B, that 80-20 coverage, Part B has no out-of-pocket maximum. So you're paying that 20% all year long. Now, then it becomes a question of how do you actually make these choices. It's the same in private insurance. You want to make sure that you're picking a plan that actually covers the providers that you go see, that covers your prescription drugs, and that covers the pharmacies that you're going to. Now, because that lane on the left has that 20% out-of-pocket cost all year long, some people opt to buy supplemental coverage. And these plans are called Medigap Plans, or Medicare Supplemental Plans. Every company sells the same plans in this chart. So they're lettered A through N. They could not have picked a worse way to name these plans, because Medicare's Part A through D are not the same thing as Medigap Plans A through N. And frequently I have people come to me and say, I have Medicare Part F. Well, actually you don't. You have a Medigap Plan F, which actually turns out to be one of the most comprehensive Medigap plans because it picks up all of the out-of-pocket costs that Medicare doesn't. Part C would be the next most comprehensive. Both of those plans are going away next year. So Congress chose to eliminate those two plans. So if you have FRC now, you can keep it moving forward. If you have a Medigap plan now, you might be able to opt into an FRC plan in the future, but anyone who's newly eligible for Medicare will not have access to an FRC plan. So when you're thinking about Medicare choices, lane 1, you're going to pick your original Medicare in Part A and Part B. Then you have to decide if you want a prescription drug plan, and the answer is yes. You just have to pick which one. And then you have to decide if you want a Medigap plan. Whereas your other option is to choose Medicare Part C, which is going to include your A and B coverage. Most Medicare Advantage plans include prescription drug coverage. A couple don't, so if you pick one that doesn't, you're going to have to pick a Part D plan as well. But if you go down the lane on the right, if you pick an Advantage plan, you can't buy a Medigap plan. And the idea is that you don't need one because you have the out-of-pocket maximum. And so that's the rationale. Now, every single year, you get to drive back and forth between these two lanes. So if you have Medicare, every year you can make choices about which type of coverage is best for you based on what you might be going through. So if you want to see a specialist who's outside of your Advantage plan, in open enrollment, you can move back to original Medicare so that you can go see that specialist and have it be covered. But then if the year after, you don't need to see that specialist anymore, you can move back to an Advantage plan. So it allows a lot of flexibility to be making these choices every year. And if you're doing it strategically, you're actually lowering your out-of-pocket costs, which has an impact on finances. So that was like the quickest overview of Medicare I think I've ever given. But we do have a 1-hour webinar that's recorded on our site. We recorded it just before open enrollment last year. It's still up to date. So you can take a look at that on our website if you want more information. Now, Medicaid is the other federal health insurance program that prior to January 1st of 2014 was only available to individuals who had a low income, a low resource level, meaning their assets, and had to meet some other category of eligibility. Most of the time in the cancer community, that meant someone was getting through this door here on the left, which they called the Age-Blinded Disabled Program, which is the worst name ever for a program. But this effectively meant that you had to go to Social Security, qualify for supplemental security income disability benefits, and then you could get access to Medicaid in your state. So there were a lot of barriers to actually getting into the program. So the ACA actually created 2 new ways to get access to health care. One of which was to create a new door into the Medicaid program. And this new door is for anyone with a household income up to 138% of the federal poverty level, which this year for an individual is $17,236. So if you make under that, you can get access to Medicaid in your state. And it's just income, so it's not resource or anything else that they're looking at. But the ACA made this mandatory for every state to create this new door. And then the Supreme Court got their hands on the ACA and they made it voluntary for states to participate. So as of today, this is what it looks like. The states on the left have chosen to expand, the states on the right have chosen not to, including Texas and Missouri. I was trying to think of who else was in the room. Florida. So the states on the right represent about 3 to 5 million people who would have gotten access to coverage but haven't because their states chose not to expand. You see a lot of footnotes on the slide. This is probably the slide that changes most often, and I probably should have said at the beginning that these slides are only good for today. I can't tell you what's going to happen on Monday. But these footnotes have actually been states that chose to expand after January 1st of 2014, and most of the time it happened because there was a change in the state legislature or in the governor of that particular state. If I had more time, I would tell you about all these states in red where there are things happening right now to potentially make changes in those programs, but a number of states, including Idaho, Nebraska, Utah, and Maine, because their state legislatures wouldn't expand past voter propositions to make it happen. So the second way that the ACA created a new way to get access to health insurance is through the creation of state health insurance marketplaces. And in California, our marketplace is actually called Covered California. We run our own program here. But there are some benefits to buying private insurance through the marketplace. The first being is that there's a cap on the out-of-pocket maximums in all the plans sold through the marketplace. So this year you can't find a plan, or you shouldn't be able to find a plan, that has an out-of-pocket maximum that's more than $7,900. But there's also financial assistance to buy a plan in the marketplace based on your income level. So there's premium tax credits, which lower your monthly premiums, and then there's cost-sharing subsidies, which lower what you pay for your co-pays, deductibles, and your co-insurance amounts. Also, all the plans sold through the marketplace are standardized, so you can actually compare apples to apples and oranges to oranges. So the way that they're standardized is by their cost share. So the lowest level of coverage is a bronze plan, which is a 60-40 cost share. Silver is 70-30, gold is 80-20, and a platinum plan is a 90-10 cost share. So this is what it looks like based on income level. If you have a household income up to 138% of the federal poverty level, you have access to Medicaid in a state that has expanded Medicaid like California. If you're between 138 and 250% of the federal poverty level, you have access both to the premium tax credits and the cost-sharing subsidies. If you're between 250 and 400% of the federal poverty level, you have access just to the premium tax credits, but not the cost-sharing subsidies. And if your household income is more than 400%, you still can buy a plan in the marketplace, you're just not qualifying for financial assistance to do that. So basically, if you have a household of 4 making under $100,000 a year, you're getting some type of financial assistance to buy coverage through the marketplace, which is a large majority of our country. But I will mention that California's legislature and governor just passed a budget that, in California specifically, extended the premium tax credits up to 600% of the federal poverty level. Now, every year you have the opportunity to make changes to your health insurance coverage during open enrollment. Medicaid applications are accepted year-round. The marketplace open enrollment typically happens in the fall. It's already closed for 2019, but for coverage for 2020, it's going to start November 1st and go through December 15th. In California specifically, it's likely to extend through January 31st, because last year that is what California did as well. Medicare open enrollment is October 15th to December 7th every year, and if you have an employer plan, it could be any time of year where you face open enrollment, but if your employer has a calendar year plan, it's usually in the fall around October. But we know that not everything happens in life during an open enrollment period, so if you lose your coverage during the middle of the year, you actually get a special enrollment period to make changes to coverage. So for example, if you lose your employer plan, you could pick COBRA, or you could get a 60-day window to buy a plan in the marketplace. So you have more choices than you previously did. So I want to walk you through an exercise of how to actually choose your health insurance coverage. And this applies if you're comparing marketplace plans, if you're comparing 2 employer plans, if you're comparing a marketplace to an employer plan, or if you're comparing Medicare plans. You actually have to do some math. And I thought by being a lawyer I wouldn't have to do math in my life, but it turns out that's not the way life works. So I've narrowed down 3 plan options for this imaginary individual. And the first one is the bronze plan that is $173 a month premium. It has a $6,000 deductible and a $6,000 out-of-pocket maximum. I picked a silver plan in the middle, which is about another $100 a month. It has a $2,500 deductible and a $5,200 out-of-pocket maximum. And I picked the most expensive platinum plan to this individual that's another $120 a month, but has a $0 deductible and an $1,150 out-of-pocket maximum. So just based on looking at these plan options, assuming that you're going to hit your out-of-pocket maximum during the year, because most of the time when we're talking about cancer care, you're going to do that, which plan actually ends up being cheapest by the end of the year? Can you tell just by looking at them? Well, I can't, and I've already admitted I'm not good at math. So what you have to do is actually do the math. So you take the monthly premium and you multiply it by 12, because that's how much it costs you to have the plan for the year. And then you add that to the out-of-pocket maximum, because that's the most you're going to pay out of pocket for your medical expenses. So then which plan ends up being cheapest?
Quick question on
Yes.
this. So the monthly premium does not go towards your out-of-pocket maximum?
Correct. Your monthly premium does not go towards your out-of-pocket maximum. It's only your co-pays, your deductibles, and your co-insurance or cost share amounts. So which one ends up being cheapest? In this case, it's the platinum level plan, by a little more than $2,000. So we do this exercise all over the country with all different plans, and it never comes out the same. Sometimes it's bronze that's cheapest, sometimes it's silver, so you can't assume. You actually have to do the math based on whatever options are presented to you. And again, you can compare marketplace to your employer plan. Or if your employer gives you multiple options, you can do the same math to actually figure out what's going to cost you less. Unfortunately, most people only buy plans or pick them based on the monthly premium, because no one really understands how the out-of-pocket maximum works, and that's really where people get hit. So when we talk about the financial toxicity of a cancer diagnosis, and the most effective way to prevent that, it's by doing this. Making sure that you have adequate health insurance with the lowest out-of-pocket costs is the most significant way to actually lower your out-of-pocket costs for healthcare. But you still have to pay attention to the details of the plan. So you want to make sure still that your providers are actually covered, that your doctors and your hospitals and your pharmacies and your prescription drugs are all covered by whichever plan you choose. So I've mentioned this a couple times, but I'm going to drive this point home one more time. You can actually make these decisions every single year, regardless of what type of coverage you have. If you have your employer coverage, you can be looking at those choices and comparing it to what's available to you in the marketplace in your state. You could be looking at your marketplace options, and you could be doing the same thing in Medicare as well. I did also just want to mention with respect to healthcare finances that we do provide a drug discount card in partnership with Needy Meds. I will actually bring some tomorrow. Every time you go into the pharmacy, you should be asking the question, what does it cost for my co-pays if I use my insurance, and what does it cost if I use a drug discount card instead? And it doesn't have to be this one, it can be anyone, but the point is to ask the question, because oftentimes you may find you can pay a lower co-pay. Actually, Needy Med says that 80% of the time people pay less for their co-pays when they're using drug discount cards than when they're using their insurance. You might not, but it doesn't hurt to ask the question. And that's really, we use this as a tool to remember to ask the question, because pharmacists don't typically offer up that information. It's something you have to proactively ask for. So, question? Yes?
So if the courts uphold that ACA is not constitutional, does it completely go away?
Yep.
So if we switch to ACA from our private health plan and then it goes away, then we're...
Oh, that's a good question. So there's a difference between the law going away and if you have a marketplace plan, you've already contracted with the insurance company for that plan for the year. So your plan isn't going to disappear.
For 1 year, though.
For the remainder of that year. But you also have to remember, health plans actually don't want the ACA to go away, because now we've established this process and they have new customers that they didn't have before. So it's unlikely that plans are going to not renew coverage. It could be that plans decide to increase the cost of those plans, but they can do that every year regardless, and frankly they do. But beyond that, no one really knows what's going to happen.
Could they also reinstitute the existing thing and say we can't?
Sure.
So then we could be completely out of luck if we risk, that was why I never went over. I was afraid it was going to get overturned and then I end up, nobody could insure me.
So this is a really interesting, I'm glad you asked the question because it's an interesting question for everybody right now, and I think that I don't have a good sense of how we're going to unravel nearly 10 years of legislation at the state and federal level and all the changes that have been made to the healthcare system which come under the ACA, but no one else does either. And so I would say if you've chosen a marketplace plan, regardless of what happens, if the Fifth Circuit decides tomorrow that it can't be appealed and there's a decision tomorrow the ACA goes away, your plan isn't going to go away. It will continue throughout the year. But then we default back to what laws existed prior to the ACA. And the most relevant one is the Health Insurance Portability and Accountability Act, or HIPAA. And HIPAA had a requirement that if you have individual insurance, there's guarantee issue from year to year. Same thing with employer coverage. Employers are required to provide you with insurance if they're providing coverage to all of their employees. So they can't deny you based on a pre-existing condition, but they can impose a pre-existing condition exclusion period. So if you start a new job, you could be denied coverage for any of your pre-existing conditions. You'll get insurance, and if you break your arm, they'll cover that, but if you have a cancer diagnosis as a pre-existing condition, they won't cover anything related to a cancer diagnosis for up to a year. HIPAA capped it at a year. So you can eliminate a pre-existing condition exclusion period by having prior creditable coverage. So as long as you had health insurance coverage prior, without more than a 63-day gap in that coverage, it will eliminate the pre-existing condition exclusion period moving forward. And I can't believe I remembered all of that from 10 years ago. So I have to go back and relearn HIPAA if I'm going to have to talk about this, which I really hope I don't. Because HIPAA, it created some protection, but it also created a lot of hoops that people would have to jump to keep access to coverage. So in some ways, I'm saying as long as you have continuous coverage, you're okay. On the other hand, I'm saying if we lose pre-existing condition protections, it's going to be very difficult for everybody. Any other questions?
Will this also affect managed care plans?
Yeah, absolutely. If the ACA goes away, there's so much in that law. So the closing the donut hole under Medicare, adding free preventive services to Medicare, providing grants to rural hospitals, providing grants to doctors to go to medical school to work in rural areas. There's so much in the ACA as a law that people don't realize because it's just not talked about that would all really, with the stroke of a pen, go away. And how we actually manage that process moving forward is really unimaginable because there's so much. Yeah.
So where is this plan that the president is proposing is going to be there if the ACA goes away?
I am not privy to the president's plan
Because he doesn't have
to
one.
replace the
It's on a
ACA, but
300
honestly, there's, like I said, there's so much in the law that there would have to be a lot of things happen at the state and federal level. I will say that there are a handful of states, California is one, that have taken steps to codify what's in the ACA at a state level. So that even moving forward, if the federal law isn't there, there are some protections at the state level. Not everything that is in the ACA, but some of the things.
Sounds like his new program is in a package called Scott Tissue. Little squares.
I did put the disclaimer out, right, that I'm just sharing the facts of what's happened.
So our son will be 26 next year, so he's going to be on our coverage. That's kind of unrelated to this. But so does his coverage end on his birthday, or does it go through the end of the calendar?
Depends on the plan. So
Okay.
you have to look, is it an employer plan?
Yes. Well, it's actually COBRA now.
So you'd have to look to see if it ends on the day of his birthday, the last day of that month, or if it goes through the full
Okay. So
the full year of which he's 26.
okay. And then you said there's a COBRA plan for him to potentially pick up?
Well, if he's already on COBRA, then no.
I mean, when he turns 26.
Ryan, what state you're in?
Tennessee.
Are you under COBRA that's going to end at 18 months?
Yes.
One possible extension to that is if he experiences a second qualifying event during those 18 months, he could get an additional 18-month extension.
Okay. I'll go online and research. Thank you.
Or he could look at the marketplace and then compare to see what's
Sure.
better. Yeah. And certainly if you have questions, feel free to call us.
There's a card that came out several years ago, Good RX.
Yes, that's an alternative drug discount card. And actually you can have it on your phone too.
Yeah, I knew it was on the computer, you have it on your phone, and my question is when they first marketed it, they said it was good with other cards. Is that still the case, or?
It's going to depend on the pharmacy. If the pharmacy lets you use more than one drug discount card together. Sometimes a pharmacy will say, well, oh, I don't contract with that card. Use a different card, like see what other card they do take, because then even when you're at the pharmacy counter, it's worth pulling it up, which you can actually do online and show them. Any other questions? Thank you.
Thank you.